Welcome to the first 3-Minute Read podcast. I'm John Dalton, editor of the 3-Minute Read, the twice-monthly newsletter of the Healing American Healthcare Coalition. Joining me today is Ed Eichhorn, the coalition's co-founder and also co-author of Healing American Healthcare, a plan to provide quality care to all while saving $1 trillion a year. Together, Ed and I have nearly a century of healthcare experience, and we're still trying to figure it out. You can find our background and contact information at the end of the podcast, and feel free to contact us with questions or issues that you'd like to see addressed. 1 year ago, America confirmed its first case of the novel coronavirus that has swept through the world as the worst pandemic in more than a century. Knowing the stress it would produce for busy physicians and clinicians who are trying to deal with coping with the crisis, Ed and I launched the 3-Minute Read last March to summarize some of the critical issues affecting them. This is our 22nd issue. To date, we've summarized 105 articles from 50 different sources on 8 topics, including physician practices, insurance coverage, drug costs, and of course, the all-consuming pandemic. So let's dig into the current issue of 3-Minute Read. The first article that we summarized was entitled, "Crisis Showcases Corner of Europe, Derided by Trump Advisors." It was written January 11th issue. What they pointed out was that in its 2018 report, quote, "The Opportunity Costs of Socialism," quote, President Trump's advisors trashed the Nordic economic model, saying it reduced living standards. And the Nordic countries, as you can see on the map here, farther south is Denmark, Finland, Sweden, Norway. And then if you talk about all of Scandinavia, throw in Iceland, the smallest and least populous of the 5 countries. We're going to deal with these 4 in the article. Well, the World Economic Forum disagreed with the Trump administration's findings. They stated that with low levels of debt as a percentage of gross domestic product, Denmark, Finland, Norway, and Sweden have far more leeway to spend their way out of the coronavirus recession than do many of their peer countries. For example, Denmark and Norway run around 40 to 50% of GDP. I think Sweden's around 70%. The European Union as a whole is around 90% of GDP in terms of debt. And the US is well over 100% at this point in time. Well, at December 31st, 2020, 3 of the countries ranked in the top 10 among Organization of Economic Cooperation and Development countries in terms of protecting their residents from COVID-19. Norway was 5th, not including in the article, was 6th, Finland 7th, Denmark 9th, and then Sweden, which began with a failed attempt at herd immunity, ranked 24th out of the 37 OECD countries. The US, unfortunately, was 31st out of 37, getting close to the bottom of the barrel. Let's take a brief look at each of the 4 countries. What they have in common are things like universal health care, a robust social services safety net, but they're all not socialist economies, but they are export-driven free market systems that have done quite well throughout the pandemic in terms of protecting their residents. Denmark, further south, population is about 5.8 million, roughly the same as Colorado, although not mountainous at all. Denmark is flat as a pancake. Capital is Copenhagen. Denmark has the 4th highest percentage of college degree holders in the world and a health system that has strong primary and preventive care. The major corporations include Novo Nordisk, the pharmaceutical company, and if you've ever been to the Port of Elizabeth and seen those container ships, the Maersk line is Danish. There's an annual World Happiness Report that comes out, and in the last 4 years, the Danes, the melancholy Danes, have ranked number 1 worldwide in happiness. Finland, virtually landlocked, is bordered to the east by Russia, and the Russians have a very heavy influence on Finnish people. Finland is the northernmost of the 4 countries. Population 5.6 million. It's about the same as Minnesota, with a cold climate, probably even colder in Finland. They have one of the shortest growing seasons in the world. The capital is Helsinki, and the major corporation that you can identify with Finland is Nokia, the mobile phone manufacturer. Sweden is the largest in terms of landmass of the 4 countries, and also the most highly populated with 10.2 million inhabitants. Roughly the same as Michigan or North Carolina in terms of population. Stockholm is the capital, and major corporations, you can think quite clearly of Volvo, the automobile manufacturer, Electrolux, and the iconic IKEA. Norway is the westernmost of the three countries, also with a huge North Atlantic coast. Norway's economy is resource-driven. The North Sea oil strike in the 1950s was a major driver to their economy. The capital is Oslo, also host of the Nobel Prize Awards each year. Norway has the sixth highest GDP per capita in the world, so it is a very wealthy country and a tourist destination with all the fjords along the Atlantic coast. One other trivial fact about Norway, the northernmost city in the world is Norwegian. It's Spitsbergen in the Svalbard archipelago. It's located halfway between the Arctic Circle and the North Pole. It's not on my bucket list. Those are the four Nordic countries, not socialist, but strong free market economies. The bank HSBC says that the superiority of the Nordic response is largely due to generous social safety nets and high digitization, a very well-educated population. So when we look at the four countries combined, their population of 27.5 million is about equivalent to that of Texas. Texas is about 29 million. So let's see how some of these compared for the last 6 months of 2020. Let's face it, when the pandemic hit at the beginning of the year, some countries jumped right on it, others stumbled and fumbled. But by June 30th, we all knew what we were facing and what we're up against with COVID-19. So what we monitored at the coalition is how the 37 OECD member countries did for the last 6 months of the year. In other words, how well did they manage controlling the curve and keeping the fatality rate down? So the table here shows each of the four countries, the combined total, Texas, and then the United States as a whole. The population, the fatality rate at mid-year, Norway, for example, was at 4.66 per 100,000 population. The US was at 38.6. Sweden, which stumbled at the start, was at 52.1 fatality rate per 1,000. We move to the end of the year, and we see what the fatality rate moved up to. And let's focus on this column, which is the difference. So in Norway, for example, the fatality rate increased by less than 4 per 100,000. So they have continued to keep the pandemic under strong control, as has Finland with a 4.18, Denmark 12, that's a pretty good performance also. Sweden continued to stumble a bit, their fatality rate increased by 33. The four Nordic countries as a whole, about 17 per 100,000. Compare that first to the US at 66. If you divide 66 by 16, you're talking about being 4 times deadlier in terms of the increase in fatality rate here. Texas, maybe 5 times deadlier. So the conclusion is that the Nordic countries as a whole, for a variety of reasons, did quite well in protecting their residents from the pandemic. In fact, in our prior issue of the 3-Minute Read, we had an article by Dr. Tom Frieden, who headed up the Centers for Disease Control and Prevention from 2009 to 2017. He had selected countries in several different categories in terms of how well they dealt with the pandemic during 2020. He overlooked one, so we added that to the equation. We looked at Europe as a whole, and clearly Norway did the best job in Europe of protecting its residents. It was 5th in the OECD, with a year-end fatality rate of 8.12 per 100,000. The countries that exceeded Norway in protecting their residents were all in the Pacific Rim: Australia, New Zealand, Japan, and South Korea. So that's the Nordic countries.
I'd like to take a moment here, John, and talk a little bit about
Sure.
Texas, if we could.
Oh, sure.
And the reason for that is when you look at the chart that you've provided, is the performance in the United States certainly is substantially worse over those 6 months than the Nordic countries, but the performance in Texas is even worse than the average for the United States. So what happened in Texas? Well, as the pandemic grew in the United States and in Texas, we sort of locked down the country for a while. And that certainly worked because you could see the death rate in Texas was only about 8 per 100,000. But as we got into the middle of May, Governor Abbott of Texas thought it was time to open up the state. And he opened all of the restaurants and all of the bars. And he happened to do that just 2 weeks before the Memorial Day weekend. And as a result of allowing people to not have to stay at home and not mitigate. There was a lot of joy in the population about going out to restaurants again, doing the things they like to do when times were normal. And unfortunately, as the governor later admitted, they broke their confinement of personal quarantine too soon. In addition to that, the governor never required everyone to wear a mask. They didn't require mitigation once they began to reopen their economy. And as a result, they had a very large infection rate through the summer that continued through the end of the year. And it just underscores the real importance of using the mitigation strategies that the CDC has recommended from the very beginning of this crisis.
So when you don't mess with Texas, people die, unfortunately, and in this case. 3 years ago, an announcement was made that shook the healthcare establishment. Two of the world's wealthiest men, Jeff Bezos and Warren Buffett, and our most prominent banker, Jamie Dimon, announced forming Haven Healthcare to, quote, create simpler, high-quality healthcare at lower costs. And if you look at the equation, you say, well, here's Amazon, Berkshire Hathaway, and JP Morgan Chase, three huge corporations tackling healthcare. It did shake the establishment. They then went out and hired Dr. Atul Gawande, the prominent surgeon and best-selling author, as CEO. For anyone who works in healthcare, if you haven't read the Checklist Manifesto, it should be on your must-read list. It's probably one of the best books I've ever read. But of course, Ed and I are both metrics-driven engineers, so checklists and the like are not alien to us. So why did a group with a combined 1.2 million employees, which equates to probably 3 million covered lives, spread all around the country, why did it fail? A couple of reasons. Haven had a mission, create simpler, high-quality healthcare at lower cost, but never developed a real strategy. Another problem was that the divergence of interest among the three companies didn't help. These are three very different organizations. A major bank, Amazon in logistics and distribution, and then Berkshire Hathaway, a holding company with owning places like Geico, the quirky auto insurance company. So the geographic diversity also worked against them in terms of creating a very challenging and dispersed group around the country to serve. So as Dr. Gawande so aptly pointed out in his Checklist Manifesto, the volume and complexity of knowledge exceeds our ability as individuals to properly deliver it to people consistently, correctly, and safely. So stated simply, healthcare is really complicated. Next two articles deal with more of the payer side of the equation. First one is one that appeared in Healthcare Dive in January. It's the first time we've published something from that source. Quote, not enough time, not enough clarity, payers push back on CMS Prior Authorization rule, and it was authored by Rebecca Pfeiffer. And I can clearly recall that as the HMO wave swept through America in the 1990s, United Healthcare devised a way to lower its costs. It began requiring physicians to obtain, quote, prior authorization for costly procedures such as MRIs, CAT scans, and the like for non-emergency patients. In mid-December, the Department of Health and Human Services proposed streamlining the prior authorization process, and they were building off the interoperability regulations that were finalized last March. We covered that in an early issue of 3-Minute Read. If you look at the icon down here, there are several types of headaches. My least favorite headache is prior authorization required. Literally, you have the insurance carriers second-guessing medical judgment of the competent physicians. Ask basically any physician who's involved in this process, they'll tell you it's probably the most frustrating part of their job. So where are we? As expected, the pushback from America's health insurance plans was immediate and intense. They contend that it is, quote, distracting from the crucial fight against the pandemic as we enter a key phase in defeating COVID-19, as if they really have anything to do with it other than processing claims. Conversely, the American Hospital Association expressed disappointment that the proposed rule does not include Medicare Advantage plans. And as Ed and I both know from our MA plans, there are procedures where we have to get prior authorization before having them carried out, which often results in delay in treatment. And sometimes patients just don't bother. So where are we now? We as an organization, really, we support anything they can do to streamline the payer's use of prior authorizations. Just think of it, you've got a physician having to ask for permission have a procedure performed on a patient that he's diagnosed and wants to treat. On the other side of the equation, you've got a clinician. Initially it was primary care physicians, and now in many instances, it's a nurse, advanced practice nurse, who's on the other side of the call, deciding whether or not to approve the procedure. The approval rates typically run in the very high 90%. We would go even further. We'd eliminate the procedure altogether, and instead, as many other countries do, rely on post-treatment review to ferret out fraud and abuse. You're never going to eliminate fraud entirely, but if it's 1%, 2%, 3% of the procedures, let's look at it afterwards and go after the mandates, and let's not delay or deny treatment to patients who need it. And just yesterday, CMS finalized the rules. So they didn't pay attention to the pushback from the insurance plans, the lobby for the payers. So just to give you some idea of the streamlined complexity, in CMS's announcement, it said this will enable providers to electronically locate prior authorization requirements for each specific payer from within the provider's workflow. It will facilitate sending prior authorization requests and receiving responses electronically within their existing workflow, while maintaining the integrity of the HIPAA privacy standards. It will include a specific reason for a denial when denying a prior authorization request, and will send prior authorization decisions both through PAS API, whatever that is, and otherwise required by existing requirements within 72 hours for urgent requests and calendar days for standard requests. That's streamlined. So to us, the continued use of this tactic to delay, defer, and deny care second guesses medical judgment and adds cost with very little or no benefit.
Let's
Ed,
talk
any
a little
comments?
bit about the
Next one's
cost.
yours. Yes.
Okay. The cost issue is very significant and really not covered in the CMS ruling. When we wrote our book, Healing American Healthcare, through our research, we learned that on average, physicians individually spend 3 hours a week in contact with insurance companies for seeking approval for the things that they need to do. Sometimes it's a pre-authorization issue, and there are many other issues. Sometimes it requires them to actually write letters. And we compared bureaucracy staffing requirements between the United States and Canadian practices. And we found that, for example, in a practice in Washington State, there were 4 physicians in the practice, and they had 4 staff members working in the practice. 3 of the staff members worked on insurance issues, billing, collection, and pre-approval. Conversely, if you looked at a practice in Canada, we looked at one that had 12 physicians in the practice, and they had a manager for the practice who spent half of her time doing billing. There was no staff to get pre-authorization. There was just half of one staff member for 12 physicians. So that's why in our country, we spend as much as 14% of the cost of healthcare on bureaucracy. Broken down another way, that means we spend $1,000 a year for a family of 4 just for hospital and physician bureaucracy in dealing with insurance providers. And we need to reduce those costs and reduce the time. Physicians shouldn't have to spend almost half a day a week talking to insurance companies to get the services for the patients that they are treating. And that leads to another factor that I'll just mention very briefly, and that's physician burnout. Physician burnout in the United States is as high as 47% in surveys that have been done, asking patients, physicians rather, if they've ever experienced burnout. That is the highest percentage of burnout reported in any profession in the United States. So the issue of pre-authorization and the CMS move that John just reported are very important, and they have very real consequences on the practice of medicine. They ought to be addressed in a more efficient and thorough way.
Yeah, and Ed, you addressed a lot of those issues in the book, Healing American Healthcare. Unfortunately, the debate in the United States got a little bit distorted with the Medicare for All movement, which kind of people now equate Medicare for All with universal healthcare. That's just one way to deliver universal healthcare, as we've seen in many other countries. America, for better or for worse, is an employer-based system that dates back to the 1940s and 1950s. And short of a revolution, there's no other way to proceed except to continue building upon it. And several other countries like France and Germany have done so, where their universal healthcare systems are based on access with employers providing insurance. So Ed, I know you've got your thoughts on the next article.
The next article in the 3-minute read that we would like to discuss is entitled Lavish Bonuses, Luxury Trip. Health benefits brokers will have to disclose what they receive from the insurance industry, by Marshall Allen for ProPublica on January 6th. Employers-sponsored health plans cover about 150 million Americans, and most employers use insurance brokers to figure out what plans they want to cover their employees. This is generally the largest group of insured Americans in the United States are through employer-sponsored plans. And we learned through this article that a broker's base commission can range from 3 to 6% of the total premiums for the services that they provide to the employers. The coronavirus relief package included a requirement that health benefit brokers disclose to employers how much they actually make from the insurance carriers. And what we learned is that through the ProPublica 2019 report, we learned that insurance industry influences consultants behind the scenes with cash and gifts from 6-figure bonuses to expensive island vacations. The National Alliance of Healthcare Purchaser Coalitions that represents employers called this new disclosure a step in the right direction. The need for employers to use brokers adds to America's highest cost among the OECD healthcare costs for those 37 nations.
I'm surprised that this act actually passed with the relief package now requiring this disclosure. That's healthy. When you think about it, to start with, the brokers getting a commission for helping to select the plan or plans that the employer will use to cover their employees. Since the commission is a straight percentage, there's no really incentive there for the broker to provide the most cost-effective solution for the employer. Moreover, on the other side of it, you've got certain of the insurance providers providing some vig for the appropriate selection. So to me, that's an inherent ethical conflict, and it's something that needs to be remedied, but disclosure is a very good step in the first direction, as the Coalition of Purchasers has pointed out. The final article in 3-minute read talks about what life may look like for us after we all get vaccinated. Ed, want to tackle that?
Sure. The title of this article is, Once You and Your Friends Are Vaccinated, Can You Quit Social Distancing? There are 3 steps to this effort that were described in this article. And Dr. Murray, a Boston University epidemiologist, suggests that the best way to set our expectations around this was to focus on these 3 strategies. Now, it's important for us all to understand that once we get the vaccinations, assuming we use the Pfizer or the Moderna sources that require 2 vaccinations, we all think as individuals that once we get the second vaccination, everything is fine. But that's really not the strategies that Dr. Murray suggests in this article. Stage 1 is what you can safely do once you and your close friends and your family are all vaccinated. You need, of course, to wait about a week after the last vaccination has been administered, but you can freely meet with each other in your homes or in a closed situation and not wear masks and act relatively normally. The exception to that, of course, is if you live with someone who did not get the vaccination and, could suffer from the virus because of age or complicated healthcare conditions. So that's the first stage, that you can meet with your friends and your family in closed situations and not have to worry about masking. The reason you have to worry about masking is that even though you've gone through that protocol, you can still have the virus within you because you can inhale it, because it's airborne, and you can exhale it, and people around you would still get infected with that virus. So that's why we have to be a little bit safer and wear masks once we get the injection and move around in our normal activities. The second stage is, it's important to understand that we won't all reach herd immunity at the same time. Your city or your state could reach immunity where neighboring regions or cities have not quite gotten there yet. And for that reason, you would still have to wear a mask. Stage 3 is the idea of getting completely normal around the entire world. And that's going to take probably well into 2022 because we don't have a lot of data yet about the access to vaccines in other countries around the world. So according to Dr. Murray, she said it's really going to come down to what we learn over the next few months and how well the vaccine prevents the infection and transmission for us really to get back to normal.
So unfortunately, if your number one item on the bucket list is to visit the Taj Mahal or the Great Wall of China, that's not likely to happen until 2022. And even within the U.S., travel will continue to be regional in terms of which areas reach herd immunity first. Right now, the stats that Ed and I have looked at, it's John Denver's favorite state, West Virginia, that is leading the country in terms of getting its people vaccinated. There'll be more on that in the next issue of 3 Minute Read. Meanwhile, we at the Healing American Healthcare Coalition are very much interested in hearing your thoughts about the future of American healthcare. So there's a brief survey at that link. Take 2 to 3 minutes to fill it out and get it back to us. And we will share feedback with our listeners on the issues, including United Healthcare versus Medicare for All. As I mentioned before, there's some confusion out there where people think Medicare for All is universal healthcare. It's not. It's a single-payer, government-run healthcare system. There are other ways to provide universal healthcare, and some of our major Western democracies do a very good job of it, like France and Germany. And we'll talk about the Eichhorn-Hutchinson All-Care Plan, which is what was laid out in the book, Healing American Healthcare. It bears some resemblance to what President Biden is calling Biden Care, building on the positives of the Affordable Care Act. For example, one of the great accomplishments of the Affordable Care Act, to me, was the definition of 10 essential health benefits, which simplifies plan selection. If you want more, we supplement that with other insurance packages. So we'll be discussing those. If there's particular interests that you'd like to see covered, feel free to contact us. The contact information is at the end of the presentation. Finally, Ed also posts blogs periodically in support of the Coalition's guiding principles. Ed?
I'd like to discuss this blog briefly. The title of the blog is Strategic Compromise, A Pathway to Universal Healthcare. Our blogs try to discuss the issues that are relevant to our view of healthcare that we described in our book, Healing American Healthcare. And we believe that healthcare in America should be a right and not a privilege for those who can afford it. However, the legislative path and process for healthcare reform is complex and challenging. If you choose to read President Obama's book, The Promised Land, he goes into great detail about the challenges associated with bringing forward healthcare legislation that they faced as they brought Obamacare forward. So I believe that lawmakers need to have a compromise that works, and I've chosen to call it a strategic compromise, one that allows both sides to have a win. The Eichhorn-Hutchinson All-Care Plan provides a basis for a strategic compromise of this type. With our plan, Democrats get universal health care for all Americans, while Republicans get a reduced federal and state budget spending of about $250 billion each year. And we think a compromise of that type might bring people together to push this bill through Congress and deal with reconciliation that must occur in both the House and the Senate, which we're not going to discuss in this article. However, you need to understand that to get health care through the Senate could require 60 senators to vote for the bill. Yeah. So if that's truly the case, then both sides really need to have an opportunity to win. And our plan would provide such a compromise. Anyway, I want to thank you for listening to us today. The next slide shows our contact information. We'd love to hear from you. And of course, you can read the blog at our website at the link that we just showed.
If you'd like to join our mailing list, please text HEAL Healthcare to 22828 to get started. We'd love to have you join our mailing list. Thanks. See you next podcast.